Good afternoon and welcome. My name is Nick Davies and I'm a Programme Director here at the Institute for Government. On behalf of IFG and Newton, who are kindly partnering with us on this event, thank you for joining with us on this look at the role that prevention can play in boosting public service productivity. The new government has put prevention at the heart of its reforms plans. Last week's budget announced some preventative measures, including higher taxes on tobacco and alcohol and an increase in the soft drinks industry levy. Also committed to a more preventative approach to public service delivery as part of the spending review, and today is also the first reading of the tobacco and vapes bill, which will make it illegal for anyone aged 15 and under this year to ever buy cigarettes. With spending likely to be tight over the coming years, the theory behind shifting to prevention is clear. By intervening sooner, problems may not escalate, become embedded, or arise in the first place, meaning prevention could play a major role in improving public sector productivity. But as IFG research published earlier this year found, since 2010, spending has actually shifted from preventative services to more acute ones. So how can additional investments be made in prevention when demand is high and budgets are tight? Is it realistic to expect preventative programs to deliver cashable savings? How quickly could a shift towards prevention improve public sector productivity? And what are the respective roles of the centre of government, department and frontline services in delivering this shift? To discuss these questions and more, I'm delighted to be joined by an expert panel. Dr. Thomas Waite, the Deputy Chief Medical Officer for England, Councillor Jillian Ford, Deputy Leader of Havering Council and Cabinet Member for Adults and Health and Deputy Chair of the LGA City and Regions Board, Danny Sperrin, Partner at Newton, and Moira Wallace, former Head of the Social Exclusion Unit, known for its work on prevention, and the Office for Criminal Justice Reform. We're going to start with brief opening remarks from each of the panellists. I'll then ask them a few questions before opening it up to questions from the audience. If you are watching online, you can already start submitting your questions now. We'll have lots of time for them, and I'll try and get through as many of them as possible. Right, without much further ado, I'm going to hand over to our first speaker, Dr. Thomas Waite.
Thank you. I'll start by saying this is definitely one of those occasions when I feel I have to apologise for not being my boss. You get used in this role to seeing a certain amount of disappointment when the deputy comes, but Chris was very keen to be here, and he does send his apologies today. In terms of how we shift to prevention, I think maybe the first thing to say is that we have known for a very long time there are a wide range of disease areas or specific diseases where we can either completely prevent the onset of disease. My background is primarily in infectious diseases. You'll all be used to those vaccines which can offer sterilising immunity. There's a lot of those in the childhood immunisation programme, for example. Or indeed, and this is more in the world of chronic disease and non-communicable disease, we can either delay their onset considerably, so you shorten the period of time that people spend in ill health, or shift the onset to the right, so people experience disease later in life. That's always been the case. I mentioned vaccines. There's a whole range of diseases that are covered in the childhood immunisation programme that we are simply used to not seeing anymore in this country. Polio, diphtheria, for example, which used to be major killers in childhood, and we now see very few cases globally, actually, of polio, certainly very few here. There are then other interventions such as screening for a whole range of cancers, which have been very successful, and programs which seek to diagnose disease early to prevent complications that are linked to blood pressure and so on and so forth. And there will, of course, be some interplay between those. Some vaccines against infectious disease origins for things like cervical cancer and so on have hugely reduced the incidence of cervical cancer, and in fact they've been so successful we've been able to reduce the number of vaccines you need down from 2 to 1. So clearly, through we know from a long time, there are some cashable savings here. I think then, if you look right the way across health beyond my area in infectious disease, there will therefore be a wide range of areas in health policy, as in others, I suppose, where, as I say, you can either shrink the duration or shift it later in life, which alongside other public policy interventions have a major part to play. It's then worth thinking a little bit about what we mean by savings or the sorts of costs that people incur or that the society incurs as a result of somebody having a disease. There's obviously the direct costs, both to an individual of being unwell, but also the healthcare costs, either of late diagnosis or of treatment. Those obviously go up considerably as you involve surgery and intensive care and other areas that are, they're very effective, but become very expensive. There will then be a downstream cost of either sort of social or ongoing care as somebody enters a chronic disease state or is less able to sort of live independently. We can clearly do something about that through prevention. And that, by definition, if you are tackling disease in people who are of working age, means that keeping people in the workplace, happy, doing roles that they wish to do, and therefore contributing to the economy, is clearly a societal impact of disease, particularly, as I say, in people who are either of working age or indeed in children, making sure that people remain healthy throughout the life course. And finally, there is, and we must acknowledge this, the often undisclosed impact on family members and others of offering informal care, which we often actually, I think, overlook in considering these sorts of things. Then finally, I suppose for some things, the impact, for some of the things that we can prevent, the impact is immediate, for other it is longer term. So if you take, topical I suppose, given events elsewhere today, the impact of the original ban on smoking in public places. This is going back almost 20 years, 18, 20 years now. There was, within the first year, a 2.4% reduction in the number of admissions to hospital for heart attacks. That's an immediate bankable saving for something that has a major impact on people's lives. And actually also within the first sort of 2 to 3 years, we saw really quite a large reduction. That's over 1,000 admissions, by the way, for heart attacks, probably more like 1,200. We saw an impact on childhood asthma and admissions for childhood asthma. I think about a 12 to 15% reduction there. I don't quote the absolute number. I've come at slightly short notice, but it's around 12%, which is, again, over sort of 2 to 3 years, thousands of admissions to hospital for children. It's unpleasant to be admitted when you're a child, but that involves parents taking time off work and so on and so forth. So all of those sort of different factors play out. And you can see that whether you look in my area at vaccines, we all remember the rollout of the COVID vaccine programme and how that contributed to reopening the economy. I think the measure, there are various measures of that, but they amount to huge savings through the prevention of infectious disease. And maybe looking back historically, we're in London. Many of you will be familiar with the Bazalgette sewers, the work of John Snow to prevent cholera in the 1800s. That is an ongoing saving to society of gastro diseases, GI diseases, that we simply forget are just there. The separation of clean water and sewage has done us an enormous benefit, sorry, not just here in London, but for the UK economy over hundreds of years. So maybe just wrapping up by saying, yes, there clearly are bankable savings from shifting to prevention. We've been doing it for hundreds of years. We should continue to do so. And some of the most expensive disease areas now, I think we are only just beginning to learn what we can do to prevent. A Lancet article just a couple of months ago, actually, telling us that 40% of dementia is down to a preventable cause. So I think there's a lot we can do. There's a lot we have done, but we should be ambitious to go further.
Thank you. On to our next speaker, Councillor Jillian Ford.
Thank you very much. Just one correction. I'm the Deputy Chair on the LGA's Community Wellbeing Board. I was on the other board, but now I'm on that one. So just to say that local authorities have seen a huge growth in complexity in needs within both adults and children's social care. And we've also seen a mass exodus from the private sector rental market, which is increasing the homelessness capacity that we have at the local level. And those three things put together in my own authority equates to 80% of the council's income and expenditure, leaving us 20% for over 100 other different services. So you can see there's a huge challenge there on the prevention agenda. Local authorities are the anchor institution that can actually deliver those wider determinants of health at that local level. And that includes improving healthy environments, community engagement, and targeted demographic interventions. And to this end, the Local Government Association put together a summary of proposals in relation to the prevention in their autumn budget and spending review. You can actually see this online, but it tasked and focused on welfare, public health, culture, leisure and homelessness, adult social care, children and young people. Prevention, however, has been on the agenda for over 12 years now. I can remember being on the Community Wellbeing Board before, when this was the same conversation. And we saw a reduction in hospital beds as a consequence, as it was going to be the way forward and the way to go. We spoke about having a shared narrative around prevention. From the local authorities' perspective, we see preventative services as those that intervene early in people's lives, reducing the need for later acute and reactive spend, which are vital to people living fulfilled, happy and productive lives. They also are vital to addressing the drag on our economy and social economic inequality, as already been referenced, and poor health. The LGA wants to work with the government to improve outcomes and increase the efficiency of public spending by intervening at the earliest practical opportunity to minimise preventable disadvantage. Taking physical activity as an example, Sport England has identified that every £1 spent on sport and physical activity generates almost £4 in return across health and wellbeing, strengthening communities and the national economy. This saves the NHS £9.5 billion every year by preventing illness and generates £85 billion annually in economic value. Of this saving, £5.2 billion was in healthcare savings, while £1.7 billion was in social care savings. Therefore, every pound spent on community sport and physical activity, 3.91, is generated for the English economy and society. Many places are already taking a structured long-term approach to assessing social return on investment and undertaking cost-benefit analysis of preventative approaches. And we're seeing local authorities like the London Borough of Newham, the Greater Manchester Combined Authority, and the London Borough of Camden. However, the capacity within councils to deliver this is diminishing because of that lack of funding to undertake this work. Government must restore the capacity of councils to both pilot and evaluate preventative services, analysing the impacts on and across a wide range of outcomes, and over time to get a more in-depth understanding of where investment is most effective. But this is not a quick fix scenario and requires a shift from being reactive to proactive and the resources to change. Local government has been consistent in asking the government to enable greater local flexibility and to take a more long-term, broad-based approach to spending decisions to ensure that short-term savings do not impair more enduring social and economic outcomes. We need to move away from one-year funding programmes as they've been proven not to deliver sustainable interventions. Pleased to hear that that is a suggestion that the new government is putting forward. We now have integrated care systems and partnerships, but we are seeing more proactive interventions engagement at that place level. We are also seeing greater use of technology and AI, assisting authorities to focus on what really matters. For example, social workers in Havering are trialling AI, which gives them the time and space to actually talk and look at the families without having to sit there and write the notes. But this also pulls together information strands from across a range of sources and agencies. We need the government to ensure that the potential long-term benefit of spending on prevention is routinely considered in both Treasury and departmental spending decisions. Local government is actively looking at the wider determinants across all departments. We now need government departments to do exactly the same. Recognising the importance of public health is something that we all identify, but it's regrettable that public health grants have decreased over recent years, which is counterproductive to prevention. We therefore need to see an increased investment in the public health grant and in other vital areas of public health and prevention. At a minimum, funding should be restored to the public health grant, which has suffered a cut of 27% in real terms since 2015-2016. We also welcome the implementation of the Hewitt report, which recommended that the share of total NHS budgets at integrated care system levels goes towards prevention, which should increase annually by at least 1% over the next 5 years. This should include commissioning strategies overseen by integrated care partnerships. Recognising place-based partnerships are pivotal in delivering prevention at that local level, and they need the tools to be able to take this work to that next level. Yet despite the government's emphasis on shifting from treatment to prevention, it is disappointing not to see specific funding in the autumn budget to take forward activity aimed at prevention, reducing or delaying the onset of more acute and costly needs for care and support. Hopefully this will be addressed sooner rather than later. So in conclusion, prevention requires a multifaceted, funded, data-driven partnership approach that delivers improved health outcomes, social economic well-being, and ultimately a reduction in public sector costs.
Thank you. Danny Spohn.
Thanks. So we at Newton, we partner with public services across local and central government. We've now worked with 50 or so health and social care systems delivering strategic change programmes that look at innovating how service is delivered with a real focus on productivity, but increasingly now that's focused on exploiting opportunities around prevention. Our focus particularly has been on what we talk about as targeted and proactive prevention, so thinking about groups who we can see are at high risk of a preventable outcome happening in the short to medium term. I guess just the overall case I think is stronger than ever. So over the next 20 years, the number of people aged 85 or over is expected to increase by 75%. In comparison, 65 to 74-year-olds will increase by about 16%. So the sort of do-nothing scenario is a 80% increase in demand on the care system over the next 20 years for people aged over 65. I think it's fair to say that despite a lot of good energy, to Jillian's point, this conversation's been going on for a little while, it's been a challenge to demonstrate prevention at scale and consistently achieved across a number of different local places. And I think that complexity of implementation has been recognised. I think you mentioned the Hewitt review and through the Fuller Stocktake as well have all recognised that complexity in implementation. But I think the emerging capability of technology, particularly artificial intelligence, machine learning, presents an opportunity to change that, the opportunity to use huge quantities of data to learn who could benefit from different types of intervention. That's becoming mainstream, and it can make that kind of targeted, proactive prevention approach deliverable, scalable and sustainable. A good example is a place over in the east of England who have developed a falls prevention model that can predict the likelihood of a fall in the next 12 months to 70% accuracy. The technology can read case notes, can draw out risk factors. Not only falls prevention can highlight risks of social isolation, homelessness, involvement in violence, domestic violence. So the data and technology is there, and actually the time frame to impact, in that case, that's in the next 12 months, can be short if you can take that targeted approach. So I think a lot of the question kind of comes around the implementation and the implementation gap. We've got good evidence around things like falls prevention, but have struggled to do that sustainably and at scale. There's clearly more to it than data and technology, so I think organisations that are really moving to a prevention-first approach are having to really change their whole operating model, align themselves around key resident cohorts rather than services that are being delivered, and develop a really deep understanding of the people that live in a place. And we need the whole system really to embrace targeted prevention and encourage innovation. And I think we shouldn't underestimate that's a major programme of change for public services. That's not a kind of add-on. So local systems need national support to do that. A whole number of ways. Jillian's highlighted some of them. I would highlight data sharing and information governance to timescales. It can take months to get basic data sharing protocols in place that would enable some of that stuff. And I think we more often see it as a blocker rather than an enabler in terms of data sharing. Clearly, there's other major considerations, ethics, amongst others, that I'm sure we'll touch on. Another sort of enabling point, I suppose, the leadership role required for this. I think leading this kind of complex programme of change and innovation whilst dealing with the day-to-day is really tough. A service director said to me recently, this sounds great, but it's telling me about the problems that I don't know are problems yet. And I've got enough problems today to deal with. And that, I think, is very true of where a lot of people's mindset. So there's a job to create the headspace and create the time and capacity to be able to deal with some of this. And I guess maybe the last point, I think taking the proactive approach, being data-led, kind of underpinned by technology, I think it does challenges the notion maybe that significant investment in additional preventative services is required. What we see is that use of technology, use of data to highlight those at-risk cohorts can mean we can target what are today universal services towards the right groups of people. So again, using that falls prevention model, we're seeing £700 a month reduction in cost of care and support by using existing, be it enablement services, technology, assistive technology, voluntary sector, handing out those services that already exist, but we're able to worry about these 1,200 people rather than the 20,000 that live in a place. So I think that's, wrap up there. I think it's, there's a lot to be optimistic about. I think it's a lot of potential, but it's a major programme of transformation to close that gap.
Thank you. And our final speaker, Moraira Wallace.
Thank you. So I've got a slightly different angle on this because I'm not currently working in government, either central or local, but I'm going to talk from the experience of having done so in the past, and I'm going to talk about social prevention, so not so narrowly focused on health, although health can play a role in social prevention and can be a beneficiary of social prevention. So I would like to say that prevention is possible. I've seen it done. I have done it myself. My experience comes from mainly from the experience of running the social exclusion unit, which was set up in the early days of the new Labour government to look at, I think the phrase was, joined up problems that might require joined up solutions. And it was effective. It sort of comes back to your point, Danny. It was giving a bit of government, which I had the good fortune to lead, the headspace to worry about all the things that no one else was having the time to get to. So we worked on a project basis. We're almost a think tank in government. And we were asked to look at issues like the very high level of school exclusions, the high level of school absence, teenage pregnancy, rough sleeping, reoffending by ex-prisoners. And to those of you who've worked in these areas, you'll know that they are all areas where the risk factors are quite easy to see, but can easily not get dealt with by mainstream services, and then they get worse, and then a more expensive intervention is required and may be quite difficult to make it work. And what I learned in the course of that is what a difference it makes to take issues like this and give them focus, give them time from someone who doesn't have anything else to do, basically, so that they can have the whole of somebody's headspace. They need time, and I think they do benefit from being led in central government, but not if that means you never talk to anybody else. So the way we worked was very outward looking. We tried to draw on academic research to go and talk to people who were experiencing this, who were experiencing the problem themselves or on the front line of dealing with it, and to see what other countries did. And on all these issues, we worked through a really simple set of questions. What is the problem? Actually, do we actually understand the problem we're talking about, where and to whom it is most likely to happen? Why does it matter? So what are the costs, the financial costs, where are they borne, and what are the personal costs to the people who are living with this? Why does it happen? And sometimes that will be about actual individual people's circumstances, and sometimes it will be a tale of public services that are simply not very well designed or not properly resourced or something. And then you would try and develop a problem analysis and produce integrated solutions to all that, and get everyone in government to agree, and set up an infrastructure to deliver interventions working with the front line to try and deal with it. And we were very fortunate that we reported to the Prime Minister, so we knew we had the Prime Minister's backing, but we also had really close links with the Treasury, who organised processes within the spending reviews that picked up these issues and tried to allocate money and indeed targets, because this was a government of targets, to promote actions across a range of government departments. So this wouldn't be at all interesting if it wasn't for the next thing I'm going to tell you, which is that an awful lot of these things worked. So we wrote the teenage pregnancy strategy. Other very clever people implemented it for over a decade. And people thought it was very charming, but unlikely when we set a target to halve the rate of teenage conceptions. And it wasn't met by deadline. It wasn't met in the 10 years that we set, but it was met in 14. And now everybody wonders, why did that happen? But actually, it was a really sensible policy prescription, adapted as it went, and it had implementation resources, and it was cross-cutting, and it's a case study of how to do it. But that wasn't the only program that was successful. So school exclusion also reduced by a half. It's gone right back up again since to where it was before. School absence, which is a huge problem now, reduced for secondary schools by 40%. So really, really quite big changes that don't happen by accident. So I offer these as a model of hope. None of this was easy to do. The role of the unit was as a catalyst. It didn't implement these things. These things were implemented by absolute mainstream Whitehall departments, either on their own, working with the front line, or in partnerships. I would like to add that I talk about these issues as if they're single issues, but many of them are connected. So one of the top risk factors for having a teenage conception, and indeed a teenage birth, is to be an absentee from school. Similarly, drugs, alcohol, poverty, youth offending are all interwoven as risk factors and possible risk outcomes from these things. So Another way to promote prevention is to look at these issues in a wider joined-up context. I'm one of a small group of people who thinks it might be quite nice if this country had a youth policy, and actually looked at all the things that can go wrong with teenagers and all the different ways that those can manifest themselves, and looked at how the state might be a bit better equipped to support people through those transitions, after which they will emerge to meet every single one of the government's missions. And they all lived happily ever after.
Well, I think we can end the event right there.
Absolutely.
Right, I'm going to move on to some questions quickly before opening it up to the audience. Thomas, I'd like to come to you first. Lots of the preventative actions that would be beneficial for people's health and could ultimately reduce costs for the NHS are the responsibility of other parts of government. So, Department for Transport and Active Travel, or Department of Energy Security and Net Zero on pollution. I think one of the goals of the Health Mission and the new Health Mission Board that's been set up is to try and coordinate that action around Whitehall. And I wonder if you could say a bit more about how that is working so far and what's being done ahead of the spending review to try and make sure that all parts of government are pulling in the same direction when it comes to prevention.
Okay, I'm going to slightly dodge the question as I'm not on the Health Mission Board, so I can't tell you exactly what they're doing. But maybe if I sort of point to a couple of examples, that are fairly obvious, I think, at the moment. I mean, the first is if you look at today's announcements about the government's intention on tobacco and vapes, and put that together with announcements, I think a couple of weeks ago now, from DEFRA, so the Department for the Environment, on action on disposable vapes. One is very much an environmental issue, one is very much a health issue. But if you look at graphs of the ongoing slow drop in cigarette smoking, but the enormous takeoff in 16 to 24-year-olds of overall nicotine use, you can see that these add up together to things that very much fit with the purpose of the missions, and some of the things that have been added to the tobacco and vapes proposals are around, specifically around preventing the exposure of children to cigarette smoke. So I think you can see there things coming together about what are the talents of all of government, or where there are aligned purposes for different government departments around a common cause. That sort of makes sense. And from the spending review, and I should probably declare, I mentioned earlier on, but I'm very much more on the sort of infectious diseases and emergency preparedness side of the CMO office. There was an announcement coming out of that for £460 million of investment in pandemic preparedness. That is necessarily all of government. Because as we saw during a pandemic response, it's not the health department that can do everything there. In fact, it's not central government that can do most of the action there. There's the role of local government, which is very much often where people will identify with and look for their services far more than central. So I think on those sides, some early wins there, but we are, of course, at fairly early days. On your point about other departments having a role to play here, actually, I think it's more than that. It really is where prevention happens. I mean, we think of prevention in health being about the role of the NHS, but that's actually what I consider secondary prevention. Something has already gone wrong, and then we prevent it getting worse. The role of primary prevention, as you say, about what the Department for Transport and others can do to encourage active transport. It's good for net zero, it's good for reducing carbon emissions, and it means people are able to walk or cycle more. They are healthier. Health gets a net gain from there. That applies right the way across government. So primary prevention is all of our responsibilities, secondary prevention in the NHS, and then there are a relatively small number of specialised and commissioned prevention services that I think will always have a home logically in health. So early days, but I think some examples of early wins there.
And Jillian, I wanted to ask you a related question, which is that, as you mentioned, a local government does a lot of preventative work, but very few of the financial benefits from that work ultimately accrue to local government, instead accruing to the welfare budget or criminal justice or health, etc. And I wondered what the kind of right balance is from your perspective on the one hand, having kind of ring-fenced grants. So you mentioned the public health grant, which has shrunk, but perhaps not shrunk as much as it might otherwise if it hadn't been ring-fenced, versus giving local authorities much more flexibility over how they spend their budgets, with the risk that that might be sucked up by those acute pressures like adult social care spending, children's social care spending, and homelessness spending. So do you think local government still does need some ring fences around preventative funding, or?
It doesn't allow for innovation if it's all ring-fenced. You do need to have that capacity and ability to put where it is needed. So, for example, I think we were talking more targeted support in certain areas, demographic needs and demographic demand. But if all the money was ring-fenced, that would make it very constrained, and every local authority would be doing the same thing. And you can't all do the same thing because you have all different needs, different pressures, different numbers, etc. So one of the biggest issues we've had up until now is the honeypots, where you're having to bid for funds for certain things. We've been told that's now going. Fantastic, that's good news for us. But we also need to see the longer term funding streams so that you can put in those sustainable preventative measures. It's been 1 year programs, and you can't make anything sustainable within 1 year. If you're talking prevention, it takes time to embed, it takes time to do that cultural change and make those shifts. So yes, we do see the benefit of having some ring fence funding, but absolutely we do need the ability that the local place can deliver projects and innovation on prevention, which fits their area.
Thank you. Danny, both you and Moira talked about Headspace and how difficult that is when acute pressures are so high. How is that Headspace created? Who gives the permission for the Headspace for people to work on other things? Is that something for ministers or central government, or is that about leaders locally? Who should be creating that Headspace?
I think it has to come locally to some extent. I mean, there's never going to be a sort of top-down direction, I suppose, that that relieves acute pressure to the extent that. So I think it has to happen locally, and I think it's only sort of through local dynamic that will understand what's the right way to do that, what's the right way to use the time. We see consistently. I mean, sort of talking about the short and long-term funding. Sitting in a discussion like this, somebody talking brilliantly about the benefits of their falls prevention service, another person saying we've just cut our falls prevention service because we've had to redivert the money to here. And so I think there's lots of different ways you can come at it. I think financial is one strong way. But I think the leadership role I think has to be done locally and through through collaboration across health and social care, through the integrated care system. I think gives the potential to do.
And Maura, I was interested in what you said on the spending review process. And obviously we are now looking ahead. The government is about to start a new multi-year spending review process to be published in the spring. I think probably fair to say, not unreasonably given the time they had to do it, that the budget was done in a relatively traditional way, with spending bids made by departments, bilateral negotiation with the Treasury. But the government has said it wants to take quite a different approach to this spending review, for it to be mission-led. And I wonder, from your experience, how do you actually make that work? How do you get different departments collaborating rather than the sort of normal dogfight as everyone tries to protect their core funding?
Well, I'd like to start by saying that a lot of people assume that the Treasury is the thing that's going to shoot down prevention funding, because that sounds very woolly and goody-goody, and they might be against that. And I would argue that the Treasury is the institution that ought to be most interested in prevention funding. Imagine if, in 10 years' time, everyone was looking at the story of how we reduce diabetes or liver disease or tackled an appalling mental health problem amongst young people and people of working age. Imagine how different a spending review would look if we had made those investments. And to continue this highly optimistic, but I think rational thought, for me, this would start with the Treasury actually commissioning up-to-date analysis of the costs of the things we're trying to prevent. This seems to have fallen out of fashion, but actually was incredibly important. in some of the reforms of the 2000s. What is the cost of crime? What is the cost of drugs? What is the cost of alcohol? What is the cost of school exclusion or absence? And the answer in every case is billions. And once you think, all right, well, if we could halve that, that would be really good. And, you know, would it cost less than that amount of money to do so? Then you become interested in this. So I say that to start with a motivation question. I think the Treasury ought to be the cheerleader for this. And it ought to be getting involved, and it ought to be seeing it as an economic problem. It ought to be seeing it as a market failure. How it would then operationalise it, I think, is the way it did before. So traditionally, yes, spending reviews are done bilaterally, but they don't have to be. And there were quite a few spending reviews in the 2000s where, I think we're talking the days of Gordon Brown as Chancellor, there were cross-cutting spending reviews. So there was a cross-cutting spending review on deprived areas and how should the government be spending any extra money it wanted to put in deprived areas. There was one on early years, there was one on young people at risk. I was involved in 2 out of the 3 I've just mentioned. There was another one on drugs. And it actually consisted of hey, the IFG is in favour of this. The IFG is in favour of strategy. So it consisted of government saying, strategically, we've got a very big drugs problem compared with other countries. It sounds like it's going to be the business of more than one department. They're all awfully busy. Let us sit together and work out how we would rewire spending targets, institutions to deal with that. And these spending reviews, I mean, many of them were fed by things done like people like me, but many of them sort of started almost from a clean sheet and developed really quite important programs in institutions. So an example would be, I think out of one of them came in drugs, the National Treatment Agency, which was a phenomenally important institution in actually saying we have lots of people who have a drug problem and who need treatment. It needs to be great treatment. We need to keep going at it to make sure it works. We need to be funneling people into it. We need a big workforce. So I think, first of all, Treasury recognising it's in their interest, and secondly, doing the cost bit of the cost-benefit analysis, and thirdly, cross-cutting spending reviews.
Thank you. I'm going to open it up to questions from the audience, and I'm going to come first to the audience that is here in person. So if you do have a question, please raise your hand. If you could say your name and where you are from. If you could wait for the microphone to get to you and speak into that microphone. And if you can please ensure that your question is in fact a question and not a long statement, that would be wonderful. Okay, I'm going to come here first.
Hello, my name's Mary Della, and I represent a national drug education charity called Hope UK. So very interested in some of the things Moira was sharing. We've been funded by a local authority to deliver drug prevention to teachers, youth workers, other practitioners across the entire county, and that funding has come in partnership with the local authority and the Police and Crime Commissioner's Office. And we've found over this past year working with those professionals that there's a lot of misinformation, there's a real lack of knowledge about what works, what doesn't work, and that kind of thing, which is concerning. And I mean, we all know that prevention is cheaper than intervention. So I suppose my question is, in this really important area, which we've already heard about from the panel, what funding may be available, and in terms of strategic initiatives, we're talking about, partnerships and so on, particularly with local authorities. What might we look forward to seeing to address this really important area in terms of prevention for young people, so we prevent those trajectories which cost the country millions in the future?
Thank you. Any other questions in the room? Yes, take the lady there.
I'm Nashaba. I'm a retired teacher. I'm just wondering, doesn't the leisure service have a huge role to play nationwide in involving people?
The leisure service?
Yes.
Any particular leisure service?
Oh, well, the leisure department, because they could do such a lot of things local at local and national level with young people and older people, and
Thank
people
you.
with mental illnesses.
Thank you. Any other questions? And we'll take that gentleman there.
On Moira's last point, isn't the problem that the ensuing benefits that come to the in the spending review after 10 years will likely as not come to the other party?
Thank you. Okay, so 3 questions there. One on what about benefits accruing elsewhere, one on the role of the Leisure Service, and one on kind of available funding and partnerships. Moira, I might come to you first and then go this way along the panel.
Well, let's deal with the ensuing benefits. I think, first of all, this shouldn't be a problem. Again, it's one government. It may be many departments, but it is one government. If the Treasury, if Number 10, if all the different departments just said, actually, there are some things where Department A really, really needs Department B to do something because Department A will benefit, you will find lots of situations where it's the other way around. And actually, yes, it may not work out precisely equally, but I think almost every department is both a contributor and a beneficiary in these big cross-cutting things. And if it works out unfairly, well, we have the Treasury to sort it out and say, you deserve a bonus for being so good and so generous and doing things that would benefit other people. I think of course it's an issue, but it's completely soluble. It just takes someone to say, let us solve it. Throughout London every evening, people are splitting bills at the end of a meal. Are we saying that departments can't do that? Of course they can.
And can I just add to that, because there's a question online from Tom Lawrence asking whether we need sort of innovative gain share mechanisms and the like. Do you think it's less complicated than that?
Well, you could try that, but that all depends if you've actually, when you get to the point where there's a really brilliant idea and Department B is saying, I will not do that because I will not see the benefits, then maybe you need to go to that point. But actually, if you look back at some of the experiences I'm talking about, so let's take teenage pregnancy. Why did teenage pregnancy fall? Well, sex education got a bit better. The provision of contraceptive services for young people became less judgmental, more convenient, was nearer schools and colleges. There was more encouragement to people to use more effective methods that were more suitable for teenagers. And there was a whole set of other social changes that supported that. So who was spending the money? Some of it was being spent by education, some of it was being spent by the health department. Who benefited? Both of them. How did they benefit? Well, the education side of the balance benefited because lots of young women stayed in school for longer and are no doubt helping, contributing enormously to the economy in a way slightly differently from how they would have if they got pregnant when they were 15. How has the health department benefited? Well, again, probably there will have been all sorts of child health benefits. There will have been fewer abortions. There will have been all sorts of things. And none of that faltered on the basis of someone saying, I'm not going to do it because I don't see the benefits.
Thomas.
Thanks. Shall I maybe say a little bit about the question on leisure services? I think it's a classic of the part I was speaking about the role of all, not just government departments, but all of health and society on public health. There's something called the Dull, Green and Whitehead model, which is quite a nice sort of rainbow that looks at all different aspects of the environment and their impact on both physical and mental health, as you said. So I suppose when we think about leisure services, that is, by necessity something which is provided through local government. But the benefits are felt everywhere. And it's not just about swimming pools and sort of single places you go to. It's the health benefits of having access to green space, of having somewhere to run, to have playgrounds as a child, and indeed third sector interventions, things like Park Run. So I completely agree with you that access to those sorts of services is critical for preventing ill health. It's critical through the life course, in the sense that having access to that as a child is really important, actually, physical activity, the link between physical activity and reducing levels of obesity, which are now very, very high, actually, in some parts of the country in particular, in childhood. But also in terms of the measurable benefits, the question you asked at the beginning, if you go to the other end of life where people, for example, may be awaiting a joint replacement to go in for a knee replacement or a hip replacement, there is good evidence, actually, that being able to lose some weight before you have a hip replacement, or indeed improve your cardiovascular reserve, your respiratory reserve, can reduce the duration of your admission to hospital by days. Even if you just take one day off the average duration of a elective hip replacement or knee replacement, you can see that has a bankable cash saving on the waiting list. The people on the waiting list cannot work. The people who are then off the waiting list and have had their can go back to work. So there's the knock-on impacts going through those 4 different types of savings I mentioned earlier on are clear and are measurable. So I completely agree with you. How we use those sorts of things as community assets is pretty critical, I think, to the missions.
Thank you.
Thank you. Yes, starting with Moira's drug prevention programme. In Havering, we have the Combating Substance Misuse Strategy, and that's been a complete partnership piece of work. So that's voluntary sector, private sector, health partners, police, etc., etc. So the development of that is the pooling of budgets, pooling of resources, the human resources. So it needs to be a collective. It's not something that can be done in isolation. So if that's not happening, you can take that away and say we need more people at the table so that you can get those conversations going. In relation to the question around leisure services, absolutely, and I referenced that in Sport England's funding analysis of the impact that that does have on prevention and health and well-being. And just as an example, in my local authority, I've linked our GP network, primary care network, with our leisure providers because the GPs were not referring people to the provisions that we had in our leisure providers on Parkinson's, heart conditions, healthy weight management, etc. So they've now got that strong link and they can make those referrals so we can maximise on that. But it's looking at our parks and open spaces. Are they accessible? Are they available for everybody? And I think COVID was a prime example of where that came into its own. Everybody wanted to get out. They hadn't been to these places ever before, and they were finding their own mental well-being was being improved as a consequence of that. And available funding, good question, where is the funding? Something we're all asking questions on. But again, it comes down to that partnership working. And something that was mentioned earlier on, we've engaged in a joint commissioning process so that we have somebody that is employed by the local authority and the NHS so that we are getting that closer link, trying to get over those barriers of the data sharing and the legal processes that are so very different from our health partners to local authorities so that we can increase and improve those prevention agendas and get things moving at a quicker pace.
Just build on a couple of points and come back slightly to your question earlier on Headspace as well. I think the timescale is really important here. I think the temptation can be with some of this stuff to think about the 10-year examples, of which there are lots. I think we see increasing examples of prevention that can have an impact in 12 months, 24 months, 36 months, which big city we've done some work with have set up integrated neighbourhood teams to target the 5% of people in a place that generate 50% of the health and social care demand. They're seeing GP attendances down a third, A&E attendances down a quarter in the space of 12 months or so of those things being up and running, which those and that can then help you work your way back upstream by doing some of those things that do have a measurable benefit in the short term. So I guess just a bit to challenge that sort of, let's not always think about as well as thinking about the extremely long-term measures, some of those shorter-term measures that can have a really meaningful impact are important.
And Danny, I want to come to you with a question online. So someone's asked, lots of commentators are very bullish about the potential of AI automation. Yeah. Is this realistic or just hype? And is this really about prevention or is it about productivity and efficiency?
The applications, so I think it's probably a bit of both, isn't it? I mean, I'm sure it's overhyped. I wouldn't dispute that. But I think the application, I think seeing the kind of real application, so, I touched on before, seeing one of the models we're working with, which takes all case notes written about a person in social care and in healthcare, if we've got the data, reads them, draws out risk factors, reads through pages and pages of information that a practitioner would take hours to get through and draws out key risk factors that then can influence someone's likelihood of becoming isolated or their care breaking down. So I think there's very real application there, which is really, really valuable. And then having the intelligence to know which patterns to pick out that are going to sort of lead to an outcome. So I think it's real. I think the potential is real. Clearly comes with caution. And actually, to the conversation we keep coming back to on data sharing, sort of only as good as the data that we can feed into it. So I think that's really important.
Can I just come in on the example when I mentioned about social care? In the past, they go to visit a home, they can't actually see what's going on in a home because they're having to sit there and take their notes. But now they can sit and look at Carol in the eyes, they can talk to her, they can see the room, and they're not having to sit there taking notes, and it gets that closeness back again, which social care should be. So our social care workers have really found it quite enlightening, and they've really embraced it, and they were very excited to get this on board. So I'm sure we'll see more of that, and it will help with more of the assessments and speeding up some of those processes where there is that lag, and can reduce some of those complexities around the decision making.
Thomas, a question for you online, which is, how do you think we can overcome the nanny state rhetoric when proposing primary prevention policies?
It's an appropriate question at the moment. I mean, if you take the smoking legislation as an example, whether you look at the YouGov data or indeed almost any public opinion survey, the public are in favour of the measures that are being put forward. I think that is in itself the single most overwhelming narrative here, and that's right the way across the age spectrum and right the way across political support in the general election. No matter how you cut that data, people are in favour of what is essentially about preventing the next generation from being exposed to an entirely preventable source of cancers, of strokes, of high blood pressure, of heart attacks. So I think sticking to those demonstrable facts, I don't want to quite say in our lane, but being very clear. I mean, I'm sort of talking from my perspective as a medic about we can measure the impact of these and they are as follows, is probably the most sensible way to do that. And the misinformation and disinformation was mentioned earlier on. I think that plays in to the same narrative. And this happens actually quite a lot when we're talking about vaccines as well as sort of nanny state accusations. Misinformation I sort of define as where there is accurate information out there, but it's been misinterpreted. Disinformation is deliberately wrong information. And actually, where people have come across misinformation, explaining either from a point of expertise or at least from knowledge, where this is simply being misinterpreted or why the taken message somebody has taken from something which is technically scientifically accurate is incorrect, is probably quite helpful and accounts for the vast majority, I think, of the battle that we have on our hands quite often around public health measures. Disinformation, I think, needs quite a different approach, and sometimes engaging on the terms of somebody who is deliberately deploying that information you're on the wrong foot to start with. You need to sort of step back to what the actual scientifically accurate information is. But certainly on the overall nanny state point, people are in favour of the measures that are being put forward today, and I think that's a very good thing and shows that people have registered that this is a way of preventing harm to children.
Worth noting, we ran an event on prevention at Conservative Party conference, and Steve Bryan, the former Conservative chair of the Commons Health and Care Committee, made an argument for those policies from a Conservative perspective. He said it was about a smaller state than would otherwise be necessary, and that syntax is actually, well, that was about people taking personal responsibility for their own choices and the costs associated with that. So you can make the argument from that side of the political spectrum.
You can, and another part of it that comes up from time to time is about the nanny state. It's about taking away people's liberties. I think particularly if you look at things like cigarette smoking, where when cigarettes work as intended, they addict people for life. That's the business model. Yeah, I mean it's not particularly complex. Addiction takes away your choice to stop. That is very definitely about your liberty and your ability to do things that you control with your lives. There is a political philosophy angle to liberty and choice, but in addiction it is fairly clear that if you are helping people avoid becoming addicted at an early stage in life, and most people who are addicted to nicotine say they wish they could stop, but they can't, then absolutely that's an argument that applies across different political beliefs.
And Moira, I want to put a question to you from online. It says, how do we overcome the problem that existing productivity metrics do not value the benefits of prevention? At the moment, prevention can make productivity metrics look worse because there are more inputs and fewer outputs. And indeed, that's certainly one of the factors that I think has boosted the official public sector productivity figures from the 2010s, when the government cut back on a lot of preventative spending, but the disbenefits of that are only really being felt now.
Ooh, that's a good question. So I'm not sure I'm terribly familiar with the productivity metrics we're talking about here. Indeed, I always wonder how public service productivity is measured so accurately.
That's a whole different
It
video, isn't
sounds like a slightly an act of fantasy. But let me put it a different way. I think to get prevention to happen, you actually have to have a clear idea of what sort of caseload someone could deal with, of what sort of people, and what kind of change they might be hoping to achieve. And I think quite often in prevention policies that aren't properly thought through, no one asks, so how many potentially persistent absentees are you going to be working with? And if the answer is, thousands, well, that's probably not going to work. This is a more individual game than that. So I think my answer to this person would be that prevention needs its own metrics that are set up on a rational basis, and that rational basis might be a bit experimental for a while, with people saying, we haven't done this here before, and we need to see, how much one person can achieve with this support, how many people they can take, how far along this journey.
Probably got time for one more question from the audience. Lady here at the front.
Hi, I'm Doretta from here. A question to all of you. Moira's given lots of examples of good work on prevention in the 2000s, but those spending reviews were notable for having extra cash to spend. We now know that there's massive pressure on services and budgets, and we also know that the first thing to cut when you've got to fund current services is usually the softy stuff where you don't see the results of cutting it for ages, like prevention. We know that local authorities defunded Sure Start centres when they were faced with cuts in the early 2010s. So what would you all do to prevent the sort of cookie monster of current services eating prevention budgets in the future?
Nice, easy question there that I'm going to ask you each to answer in less than 1 minute. Moira, I'll come to you first.
Okay, since there can't be 4 good answers to this, I'm really glad to go first.
We're going this way, yeah?
Yeah, here we are. I think we are. Bad luck. So I don't know that I could deal with the cookie monster, but I would like to say that I don't think all prevention is about money. I think service redesign can be incredibly important. So just to go back to a subject I mentioned several times, school absence. Yes, I'm sure we need to spend more money on preventing it, but what if we changed the curriculum in schools so that it was more engaging, and all those things that people actually want to study, it's possible for them to study, as well as the things we think they should? I mean, a huge problem in school absence is I'm bored, I hate it. Now, I'm not saying that would solve all school absence, but it would solve some of it, and it doesn't cost very much. So to what extent can more flexibility help? And to what extent can we actually get out of the mindset that prevention inevitably involves the state hiring people and them spending a lot of money? How can we help people solve their own problems? Give them resources, give them agency.
Thank you. Tom.
Thanks. It's an excellent question. I think I'll go back to one of the points I touched on at the beginning. Not all prevention has the 10-year lag that the gentleman sat next to you mentioned. I gave the example of smoking in public places that reduced heart attacks within a year. That's potentially even within a financial year. So you'll see those savings immediately, and they are bankable and they are tangible. If you take other prevention efforts, I would be doing myself a disservice if I didn't push new vaccine efforts. We've just introduced a program to prevent RSV, respiratory syncytial virus. Most people haven't actually heard of it, but it is the most common cause of hospital admission in under 5s, in fact, an intensive care admission. It's pretty cheap, but the majority of the impact is in older people. So again, by doing something that improves the health of babies, and I think that's the thing that, the importance of the best start in life is more than just prevention, as Moira was saying, but you will prevent the overall burden in the community by reducing the huge number of hospital admissions in older people. As a sort of double whammy, that's the sort of return on investment thing around vaccines that we can bank again. The Office for Health Economics, I think, have said that adult vaccine programs are something like a 19 times return on investment, and every adult vaccine is something like a $5,000 return. So we can put those in those terms, but I think it's important we put them in the economic terms as well as the sort of years of life lost and sort of health-based metrics that maybe are less useful to our colleagues in the Treasury and other government departments. There's a happy point in between the two, but those are two examples, for example, of where quick prevention, but also that longer term that affects all of our lives right across the life course are probably good arguments.
Jillian.
Okay, so our local authority, we have a 54 million deficit this year, up to about 90 million deficit next year, and we have to have balanced budgets. Let's move on from that. We have some very smart ideas that are taking place. So we have our local area coordinators who walk alongside people, looking at prevention, bringing them back into society, getting them back into work. We have our social prescribers, which are through the GP networks, which are doing some amazing work in getting them, getting people back out into housing, etc. And we also are working with our voluntary groups with supplying sort of 100,000 from our NHS partners. We're looking at equalities and inequalities, putting out funding pots which the local groups can bid for, so that we are having a prevention agenda there. One group, for example, he set up a men's walking group for mental well-being, and it's an amazing group. It's in a number of different places across the borough, 25 in one group, and just multiply that as to how many men are being impacted on that. So they're small pockets of money, but it's utilising and working with partners rather than the authority or our health partners delivering. So that small sum can have a big impact.
And Danny, brief final words.
Agree with everything that's been said. I think that just to build on Thomas's point, I think what we struggle with in a lot of non-medical prevention, social prevention, is that kind of standard of evidence. You have randomised controlled trials to say how effective a vaccine is and what return on investment you get. I think we lack that across social care, and we struggle to build that same. So I think the drive to build that really robust evidence case to prove the benefit and therefore get investment behind it, I think is crucial.
Thank you. With that, I'm going to bring this event to a close. For those who haven't already read it, please do have a look at our excellent report on how to make a shift towards preventative public services. Those who've tuned in today may also be interested in our one-day public services conference, which is happening on the 12th, featuring, among others, Michael Gove, Lord Timpson, and lots of others. And do keep an eye out for a future event that we are planning on doing with Professor Sir Chris Whitty.
Oh, you know you don't mean that.
And for now, though, I'd like to offer my thanks to our 4 excellent panellists, to Newton for supporting this event, and to everyone who has listened. Thank you very much.